Hello everyone, good afternoon. This is Dr. Rakshesh Shetty. I am the president of Predistas and I head the pediatric intensive care services at Rainbow Children's Hospital in Bangalore. On behalf of Predistas, I welcome all of you for the first edition of our webinar. And we picked up a topic of COVID preparedness. For most who might not, I hope you all know about Predistas. For those who might not know much about Predistas, it was an association which started in 2013 with the idea of propagating use of simulation to improve the outcomes of sick children. And we picked up a topic of COVID-19 preparedness because this is one where I think we would see the maximum utilization of how much a simulation could affect the preparedness as well as potentially outcomes of those who take care of those sick children and also the medical team who would take care of these patients. So we are very delighted to have three eminent speakers from across the globe. For most who have been following with Predistas, these are common names and they've been visiting us every year, helping us to kind of increase our trainer base with regards to simulation. So the first talk would be by Dr. Mike Shepherd. As you most might know, he's the director of child health at Starship Hospital, Auckland. He runs emergency medicine services, and he would talk us about COVID preparedness from ER perspective. And that would be followed by a talk from Dr. Vinay Nadkarni. Dr. Vinay Nadkarni is a professor at pediatric critical care at Children's Hospital of Philadelphia, and also is a medical director of Advanced Learning and Simulation Center at Children's Hospital of Philadelphia. He would talk us on the pediatric ICU perspective. And then we would have a talk by Dr. Ann Edis, who is the director of neonatology, again at Children's Hospital of Philadelphia. And she would give us a newborn perspective about how NICU can be better prepared to tackle COVID-19. And finally, I would talk about our experience of using simulation in terms of COVID-19 preparedness at Rainbow Hospitals. So first, I would just welcome Dr. Mike Shepherd to start off his talk, giving a perspective of how he has used simulation at his hospital at Auckland at Starship from emergency department perspective. Welcome, Mike.
Thank you very much, Rakshay, and a real pleasure to be invited to talk like this, and hopefully we can present some learnings that'll be useful for everyone from a COVID planning perspective, but also hopefully we think beyond that in other times as well. So look, I'm going to be talking largely around how preparedness and simulation can be linked, and talk a little bit around the broader aspects of some of the elements that I think need to be in place before simulation can be really useful. And then my colleagues, Dr. Nankani and Dr. Adis, are going to talk more about the patient-specific elements of some of those things, because obviously there's a fair element of overlap. So I'm going to talk a little bit about the structure that we found is really important to develop as part of planning for COVID, and in particular having a structure that a simulation can feed into and be part of. I'm going to talk a little bit around how simulation can help with the management of an emergency department and the structure around that, and then move on to the patient care elements. Through the talk, there's some reference material and some things that we'll cover quite quickly, and people have the opportunity to read more about that over time. So look, the first thing to say is that I think what we have done is we've set up a very clear incident management structure. We call it SIMS, but I think many other places will have something similar. I think the importance of this is that that there's going to be rapid changes, rapid innovation, rapid variations in the way we do things. And we need to make sure that those are coordinated and communicated out in a structured manner. So we've found this sort of governance structure, this sort of approach very useful. We have the same approach that's in our ED as well as in our other clinical areas, and then an overarching similar structure for the hospital, and other hospitals have this similar structure as well as other agencies outside of the health system. That way, if there's logistical concerns, then the logistics person knows who they're talking to, etc. So I think thinking about structure is very important, because one of the things that's going to evolve from COVID planning, but also the simulation related to that, is rapid innovation, rapid change. And we need a way of making sure that that's linked in with all of the functions around incident management. So that includes reporting, that includes very careful communication. And so we've really made sure to have a focus, and I'll talk a little bit more about that. And obviously, a lot of the things that you may do that evolve from the simulation and planning have external influences. They change how the ambulance service might work or how the community services might work. And so from a wider ED perspective, it's very important to have linkages around that. You can't change in isolation, even though you want to, because your changes have much broader implication. I think the second sort of conceptual thing to talk about is this concept of rapid improvement that really simulation is able to facilitate, able to really help us make rapid change. So what we have traditionally done, I guess, is we've focused on this workers imagined approach. We might sit around, dream up some protocols and pathways, and then try them out on real cases, and then maybe circle back and change the protocol 2 or 3 years later when a few people have identified some problems. With this sort of COVID approach, but also with the use of simulation, what we've been able to do, and what I'd really encourage other people to do, is to still do this expert group, but make it very rapid cycle, make it small group, maybe have a leadership group that might be able to challenge that, but then move into simulation and use some simulations, so zone 2 simulations, so scenario-based exercises, modify the pathway of the protocol, do it again, modify it a bit more, confirm how you want to do that, and then you use simulation to roll that out as an educational methodology using skills training as well as smaller simulation before, therefore, you get to work is done, which is the real work. And then that again loops back into adjusting the protocol, doing more simulation, et cetera, et cetera. And I think this is something that we can take away from COVID and hopefully build into our practice beyond that. Obviously, because we're in the middle of a pandemic, the whole thing sometimes doesn't go quite as perfectly as my diagram, but I think it's an important concept to try and hold on to as we make these changes through simulation. And if people want to learn more about the zone sort of base and the approach to simulation, then this is probably the optimal reference article to have a read of that by Peter Weinstein. So from a how does it make the emergency department better perspective, the things we've focused on are really around patient flow, triage, working with other departments, transferring patients, and of course, how does staff work together? So we've even simulated some things like how are staff going to use the tea room to ensure they have physical distancing? How do we figure out how different groups might work together and still get breaks? But also, how do we use our workspaces so that people can still work safely? One of the things that we think is a really important part of this process is screening of patients. We want to make sure that we have pathways that keep sort of patients that don't have COVID or might have some vulnerabilities separate from those that do. And so what we did was we developed a group of patient examples, and you can see some examples written there and some pictures of types of patients. And we use that to test out our screening tool and to practice with the nurses. So that's a very tabletop simulation, design some patient cases and really just work them through in real time with the triage nurses and our clerical team. And develop pathways that look like something like this, which might allow you to screen patients and their caregivers and stream them into different areas of the emergency department. It also relates, therefore, to what PPE you might use. And so that initial screening and risk tool is a very important part of our process that we've honed by using simulation. The next thing that we did was we used a tabletop simulation. We chose an example of a busy afternoon. We printed out a busy afternoon set of cases from a previous year. And we used all of those examples to work through the triage and the placement of the department. And just did that on a tabletop and used a map of the department in order to move the patients around. And we then moved that process into the real time, but using very low fidelity simulation. So simply pieces of paper with a diagnosis and an age printed on it. And we placed those patients through the triage process and various places around the emergency department to make sure we are able to maintain physical spacing between patients, maintain enough patients behind closed doors or in clean areas, for example. We found that a very useful methodology to improve the way the department was going to function in COVID. And I think the other thing to add around that is you do develop pathways and plans, but there'll always be some exceptions. And I think it's very important to remember to build into these simulations and these plans as you go through them that you still need clinical judgment. You still need senior leadership. You can't write everything in a plan. You're still going to need people to function as experts as they are. One of the other particularly useful simulations we found was really testing it into departmental function and the infection prevention functions. So we used a simulated trauma patient just with a low fidelity mannequin, and we took that patient to radiology and then back to the emergency department. We took that patient to theatre. We took that patient to the ward and then got the bed and all the nursing staff back down to the ED and worked through the ways to how they would manage their PPE, how they would not infect the doors and the other people as they walk the corridors. Those sorts of things allow you to develop a system for this type of work, which is very important and becomes almost more important than looking after patients themselves, because if you make these processes flow well, then I think clinical care goes well as well. So a very low fidelity, but important simulation. I think the next thing to note is that people are very anxious about PPE and personal protection in these types of times. And I think what we wanted to do was to make sure that departments and services and our emergency department, for example, had systems that streamed patients and made sure that we limited exposure of staff. So, for example, thinking about pathways that reduce the number of people in a resuscitation room before you get on to the use of PPE and practicing with that. So both of those bits are important. And so here's an example of that. And I really encourage people to have a look through this as they plan how their emergency department or clinical unit works, and a range of strategies to control for the safety of your staff. And you'll notice at the bottom, there's PPE, and I think most people have focused around these simulations around PPE because it's something that is quite tangible and easy to do. But I'd really encourage people to think about simulating some of those other things on this list, which are probably more powerful controls, and they're more reproducible controls, and obviously they end up using less PPE if we get those right as well. So how do we deliver more care with less changes of staff? How do we deliver more care with less changes of PPE? How do we deliver care that doesn't require PPE use? So those types of things are very important to try and simulate in practice and build into your pathway. When we got to patient simulation, we designed a series of types of simulations. So I think it's important to remember what you're trying to teach and then choose a simulation that matches that type of learning and learning outcome that you're aiming for. So, for example, if you're trying to teach someone how to use PPE or teach them their role in a new airway algorithm, you would use a very simple zone 0 piece of simulation. You might not even need a patient mannequin. In zone 1, we might be assembling the team in PPE and testing out how to do that more quickly. We might be testing out, helping to teach people how to work through a new algorithm as a team and use a pause and discuss methodology of a simple scenario with a simple mannequin. In zone 2, we might really now be testing out how do people do their work with the PPE on and communicate and have role allocation and make sure we have the right number of people in and not too many. And for that, we would have a zone 2, a more detailed scenario with some more fidelity around that from a clinical perspective and run that in our resuscitation bay so we really understand how that might work. So I think it's important to have a whole suite of types of simulation depending on the things you're trying to teach and embed for patient care. Finally, from me, I think communication is really critical in this process. I think what you'll find is that you'll make rapid changes with simulation, but then not everyone is going to be able to be involved in those simulations. And so you really need a great way of communicating those changes and those improvements, not only to your staff and say an emergency department, but to the whole hospital, because we know that people come from all over to help work in the emergency department. So we've used things like a whiteboard for COVID updates. We've used our intranet pages. We've used a separate question board where staff can just write questions at any time of the day or night and will be answered in email updates. And we've used all those hospital briefings to really continue to transmit those changes, to keep people updated about things that we're changing, whether it's through simulation or other methods, so that everyone feels updated and safe to go about their work. Vina.
Well, thank you, Michael. And I'd like to pick up and reinforce much of what you're saying and presenting, because our process at the Children's Hospital of Philadelphia was really very much the same. As part of our institution's COVID-19 critical care workflow design process, we did develop and conduct a number of simulation exercises which increased in complexity, as you were saying, progressing from the PPE and the sort of the workflow to actual sort of enactments of donning and doffing PPE, progressing to aerosol generating procedures such as intubation, and then culminating in the activation of our difficult airway team, where other individuals who might not be familiar with the policies and procedures of our special care unit for COVID management, for instance, the anesthesiologist or the emergency department or the respiratory care practitioner who was coming in, or even the X-ray technician who was coming to take the X-ray, how they would be incorporated into the flow, and how we would do crowd control and decrease the number of people who had that urge to run into the room to help. This combination of sort of a tabletop, as you were saying, work as imagined, progressing to the in situ simulations, which were sort of work as simulated, was then punctuated by work as done, as about 12 hours after we started doing these simulations with a difficult airway, a real patient presented, and we had the opportunity to debrief and further amend the policies and procedures. Our hospital has about 1 lakh ED visits annually, a level 1 trauma center, 540 pediatric beds, and about 220 of those beds are intensive care, 100 neonatal and 120 pediatric. Let me try to get this to advance forward. Let me see if I can resume. Give me 1 second. Just to give you a flavor of the of what we have seen at Children's Hospital of Philadelphia as of April 26th, we've had 196 positive patients, of which 79 were seen in the emergency department in 83 visits. And the first positive emergency department arrival was on March 16th. The age has been varied from the young to the old, and the symptoms have been quite variable. But as Michael was saying, what we were able to do for many of the simulations was to draw from our real experience and use real cases to invigorate the providers, and also to get ideas about what our challenges would be. And it was that combination of the tabletop, the in situ simulation, work as imagined, if you will, and the real work as done that then fed back into further simulations to try to address both the failure points, but also review the success points and figure out what was working well. And I think that's a really important thing to do, is not just to dwell in the simulations, on things that are problematic, but also make sure to acknowledge and understand those things that are working well in order to preserve them, because what we found in our simulations was that as we tried to fix one thing, we also oftentimes would throw something else out of kilter, and that would essentially compromise or have potential for harm. We did try to focus on those patients who had more severe illness that presented challenges and discussion about high flow nasal cannula, CPAP, BiPAP, and proning, things that either we did routinely, but we didn't think about as aerosol generating procedures, or we did rarely and needed to have teams practice how to prone, how to intubate in their PPE. Just like Mike, we had to change our usual flow patterns in the emergency department and create separate areas and rehearse how we would transport patients to and from X-ray, to and from the ward in pathways that didn't otherwise contaminate those who were not infected. And we were able to generate in our electronic medical record clinical pathways for the processes of care that could be amended quickly so that people could have access to the latest and greatest policies and procedures. We took our triage areas and had to make separate areas for the respiratory and non-respiratory diseases and those with fever and without fever. And like Mike, created algorithms that were not complete and only about 90% correct, but they gave people a guide and a framework to work on. What we also were able to do was to dissect and understand that it's not just the patient or the patient care in terms of medical management that's important, but we discovered using simulation and walkthroughs of standardized patients that managing the families and the exposure of the families and the ability of the families to comfort their children was indeed as complex as the medical care itself. And so even though we could make policies and rules about who could visit, who couldn't, where they would stay, where they would stand, could they leave the room, there were practicalities of the location of the toilets, et cetera, that they needed to use during their stay that crept up and needed to be managed and discovered. As we moved into the ICU, we found that diagramming out, even in very simple format, where people would stand, who would respond, led to many changes in our actual activation system. We stopped overhead paging code blues in the whole hospital and just used a telephone system to activate many fewer providers so that we didn't have the rush of individuals into the room and could manage the PPE. We made different locations where you could rapidly access the guidance on resuscitation. And we had to change our communication style. Using simulation, we were able to have many people who would normally be within the room stay outside of the room of resuscitation. We used two-way communication with FaceTime on iPads, headsets, and two-way radios to even enable the code leader to stand outside of the room and watch what was happening on the iPads. We had to make decisions on whether to offer ECMO or eCPR, and we used simulation to try out to see how few people we could have in the room and whether they could manipulate and accomplish complex procedural tasks in PPE, and had to modify the equipment we use, such as our ultrasound, to use handheld ultrasound that would project to an iPad rather than pulling the whole machine in the room and risking exposure. Our findings from the simulation, augmented by the debriefings of real events, led to a policy, procedure, and job aid that described the new roles that were developed for resuscitation inside and outside of the room, with a diagram that limited the number of people in the room and the location of the equipment and monitors. This was then codified, published, and put on the website for external viewing, comment, and critique so that others could use it as a starting point template, but that we could get feedback for further improvement. What we found was that our usual equipment had to be augmented. In fact, PPE and the response to the room was one of our critical risk factors. And so we made special bioresponse bags that had N95 masks, goggles, glove sets, the HEPA filters that we would attach onto our bag mask devices, impervious gowns, and also a video laryngoscope that could be used by the team to try to limit looking into the mouth and rather being able to project that to a video screen. In summary, we really followed the zonal approach that Michael identified in terms of basic procedures, donning and doffing, simple skills being trained first, then building up to in situ simulations, and then debriefing of real events. What I'd like to do is to just take the last minute or two to review a few of the things that we tried to accomplish. What did we address during simulation? 1, PPE, donning and doffing. 2, triage and distancing, laying out the patterns of transport. 3, aerosol generating procedures, such as tracheal intubation, difficult airway. 4, rehearsing code blues within and outside the unit. 5, rehearsing emergencies in the operating room, anesthesia now. 6, ECMO. 7, an ongoing orientation of new staff to the special care unit. How did we address time challenges and equipment challenges? 1, we shut down elective surgery and non-emergent admissions. That freed up time and personnel. We allocated these non-clinical care time to training and repurposing of jobs and rooms and functions. We dedicated equipment for the personnel who were working in the COVID and non-COVID areas. And we put the staff on rotation so there would be 1 week on COVID care, 2 weeks off of COVID care in case they needed to be quarantined. We used simulated equipment and purchased a little bit of new equipment, such as remote capable ultrasound, remote capable stethoscopes, and video laryngoscopes, which we didn't have enough of. And we made additions to existing equipment, such as the HVAC filters for the bags and placement of the go bags or the code carts outside of the room. We needed to get extra iPads for two-way communication. And then I'll finish by just echoing what Michael said about how did we ensure stakeholders were involved. Of course, our champions attended the numerous and daily town halls and COVID debriefings to find out the pain points of the organization. What were we struggling with? What were the learnings from the patients that were actually being seen that we could apply and train in simulation? We conducted tabletop exercises starting with 3-person teams, just like Michael did, and then expanded it to include administrators, supply chain, clinicians, and leaders to take that work as imagined and then play it out with in situ sims. We found a pause and reflect approach during the initial in situ sims to be very helpful to address points as they came up. But then it was necessary to run full simulations through and debrief after events in order to get the full flavor of what went well, successes, and what could be improved, failures. With that, I'd like to turn over now to Ann Ades, our neonatal specialist. Ann?
Yes, great. Thank you, Dr. Nakarni and Dr. Shetty for inviting me. So I will start. Let me get my slides up. Okay, great. So I'm going to take a different look at this. I'm going to take a look from the kind of microenvironment of the NICU. And, you know, and initially when COVID came up, most people thought the babies weren't going to be infected. There was a couple of cases out of China that we had heard about, but nothing severe. But really it started with me, my journey along this, from this COVID, that said, someone sent me an email, actually the wise Dr. Nakarni, and said, are you running delivery room sims for the risk of COVID-19 mothers? And my initial response was, we're in contact with them, we're gonna be talking to them in our delivery units, but since our main difference will be PPE, I'm not sure there'll be much effect for us. Another colleague of mine said, but it's not too dissimilar to the way we treat other things. But this kind of left a little bug in my ear from someone who's so wise saying that, what are you guys doing about this? He was giving a hint. And it really makes me think of this diagram where I was over here in this unconscious incompetence area where we really didn't know what we didn't know. And just that simple email reflecting on it really made me think about being consciously incompetent, meaning that I knew there was stuff that we didn't know and then we needed to learn it. So the first lesson that I learned from this that I wanted to speak to was to really listen wisely. So when someone wise says something to you, think about it, reflect on it, and really start to think, where do I need to learn more? Where do I not know? Then it next became, how do I get other people to move forward to the same place? The other people who also were thinking this is not going to be a big deal for us in the NICU. We'll just wear N95s or goggles. It won't be a problem. So the next step that I did to move us along this journey is I wrote an email. I used specific wording, not my role as a neonatologist, but my role as a simulation medical co-director. And also, everything I'd already learned from the simulation team this morning about the things that we're unconsciously competent about, the things, or consciously incompetent about, the things that I'm starting to learn about COVID and the management that we really don't know how to do yet in the NICU and our delivery room care. So my next lesson was really how to use simulation to leverage moving forward. And I think this is really important. Part of it was really just getting people in the room to talk through what the steps were going to be. We really didn't need a mannequin, as Dr. Nakarni mentioned. We just needed to have the key players in the room. This included infection prevention and control. They were actually incredibly important to have in the room because they really helped us to understand what it was that we needed. And also by having all these key players in the room, to talk about how we were going to respond to delivery of a mom that was COVID positive or unknown, really allowed us to refine our policies and make everyone understand that this is actually where details matter. It's very easy to unwittingly contaminate yourself. The next thing that came out was that we, to other leverage to get people again to buy into this, we had to make sure we have the right processes for not just the mothers and the babies that we'll be caring for, but also all the staff who will be involved. The staff had already told us, we'd already heard they were very nervous. Everyone felt like they were going to get COVID from a patient, from a parent. And so we really need to be able to reassure our staff by doing simulations that we can safely care for these patients without putting ourselves at too high of a risk. So that brings me to lesson number 3. which is really understanding the priorities of the stakeholders, which the priorities for our stakeholders really were keeping them safe, and also the priorities of the stakeholders from the hospital, which was PPE conservation. So limiting the number of people that are going to be in the room, limiting how are we going to transport these people, who really needs to be in the full PPE, when do we really need to use full PPE. This picture you can see is a very simple kind of walkthrough of where we're transporting a patient from the delivery room to our cardiac intensive care unit. We are not in full PPE here because during our simulation we did not want to use the PPE and waste anything. So, but we were still able to simulate it, and you can see we were able to figure it out. There's actually another monitor here who is someone who walks us along, who makes sure that we don't touch anything along the way and contaminate anything along the way. The next thing I learned from simulation, so this, and I had already shown a picture quite like this. So you can see this is what our codes usually look like when we have a code in the NICU. There's a ton of people around. You can imagine there's lots of challenges with this. And we've been talking for years and years and years about how to do crowd control at our codes. So we took advantage of COVID to say we need to limit the number of people who are in a room and who are at a code. We need to do this during COVID to make sure that we conserve our PPE, to make sure that we don't contaminate people outside of the room, or do the best we can not to contaminate anyone inside of the room. So again, we came up with this illustration, and you can see, again, the difference. We were able to really hone down on who we actually needed, and we simulated this with the communication pieces in the room and out of the room. And we're able to come with this as a bare bones. The great thing about this is we are using this to move forward and saying this is actually our policy moving forward for all codes, not just the ones that are in a COVID exposed newborn. So we have been able to use simulation not only to test the change, but also to move other agenda items that we've been trying to do forever forward. And we hope will truly last in the non-COVID situation. The last lesson I wanted to talk about from a COVID standpoint that we learned using simulation was innovation. And really it is, the more we learned about how we're in this consciously incompetence phase and we were learning, there's so much more that we could do with this. So we could use simulation to innovate. So now we are using telesimulation for our learners since we are not able to do live in-person simulations. So we will have a team of 3 people caring for a mannequin and 2 fellows or learners who are on using a remote platform to lead the code. We are looking at new ways of communicating during acute events with this, with even the idea of teleresuscitation. People have used simulation and innovation as a way to develop new ventilators. We were very involved in the PPE reprocessing systems that took place at CHOP. So when they decided to come up with a way to reprocess the N95s, simulation was intimately involved in that process. And I think there's still a lot of things that we don't know and that we'll innovate, or let's do research. Do newborns actually aerosolize? We've been talking about if it's so important to protect ourselves during intubations for COVID, is it not just as important if a patient has flu or another thing that when you intubate them can aerosolize? Then maybe newborns don't even aerosolize that much. And that is something I think will lead to a lot of interesting research in the future. So I think, we were able to use simulation as a force for positive change. We were approached early on in the process, actually, when CHOP was developing the remote testing sites. So we were using that whole systems testing of the tabletop sim of drawing out how the remote testing was going to take place, then going to the site and mapping out how the cars were going to drive through, and where the people were going to be that were going to be the testing, how we were going to store the swabs, how we were going to deal with getting labels printed out for the swabs. And I think now after this, people really understand much better the power of simulation. So in summary, what I would say are lessons that I've learned before and will probably continue to learn. Always listen wisely, acknowledge that there are things that you don't know, and use simulation to discover those. Learn and apply them. Leverage your expertise as a simulation person or your simulation department. Prioritize what matters to stakeholders for engagement and accelerate other agendas for change that need to happen anyway. Thank you very much. And I will pass it on to Dr. Shetty.
Thank you very much, Anne. It is for a wonderful talk about how we use simulation in the newborn care area. What I thought was, I'll share a bit of our experience of using simulation in terms of COVID preparedness. So, which is pretty much similar to what all three of you have shared. What happened in India was we announced lockdown, and with that lockdown, what happened was a lot of hospitals were told not to do any elective cases, and even the outpatient services were quite restricted. So essentially, only emergency services were to be provided. And also what happened was they designated certain hospitals as COVID hospitals. Hospitals, if you suspect patients with coronavirus infections, you are supposed to refer there. And with that, what happened was a lot of government organizations had to take up the burden of taking care of COVID patients, and a lot of private hospitals didn't have to. But this also provided a lot of unique opportunities to us, because oftentimes when we talk about simulation, our experience, especially in India, has been with the limited manpower we have, finding a time space to do that becomes extremely daunting. I mean, it's lots of clinical work, figuring out of time, getting all the team members to come and run simulation. That has been the hardest part as of now. So this time, because the clinical work dramatically dropped, provided us with this opportunity of time in terms of designing scenarios, running them, testing them, so that we can get prepared towards an eventuality where if there were to be a community spread, then they are going to come to every other hospital, and then we can be prepared. So I'm just going to share some of our experiences in terms of running and using simulation towards COVID preparedness. So like what Mike and Vinay just mentioned, I mean, initially we did plan a protocol, work as imagined. And then subsequently we used this sim zone principles, which Dr. Mike Shepard did actually allude to. For those who are uninitiated about sim zones, what it essentially says is the various intensity with which we run simulation. Now, for example, when we talk about zone 0, we're talking about essentially skill-based training. Whereas when we're looking at zone 3, zone 4, we are looking at more of human factors delivery, where we are dealing with the teams who are experts, but we are very interested in to find out why is that expert teams unable to deliver the expert care. You know, we are looking at those human factors at play and trying to explore and fine tune our work environment so that an optimal outcome comes out of it. So oftentimes it's important for us to have this objective very clear. You know, commonest mistake is, I am an expert, so I'm always have to be in zone 3, zone 4 simulation training, right? But what happens is I am a novice when it comes to preparedness of COVID-19. You know, I have not used PPE as often. So for me, even for me, or for those who are experts in terms of giving intensive care, there are many skills and areas where we might be at zone 0, zone 1. Okay, so that's very important for us to understand what kind of simulation should be offered. So when we looked at preparedness of COVID-19, we thought of starting with around zone 0 and exploring the simulations into zone 3. So when we talk about zone 0, like I said, mainly focuses on skill training. Zone 1 is more of protocol training. Zone 2 and zone 3 are more of team training exercises. And oftentimes for zone 1, you would use pause discuss, which means you would allow the scenario to run. The instructor is in the scenario, he stops the scenario, debriefs, so that people could take certain corrective actions and allow the scenario to go through. Whereas in zone 2, we would go to things like what went well and what could have been done better. And we would do more of advocacy inquiry in zone 3 and zone 4. So just to give certain example, so this is an example where initially we started off with the PPE training exercise. So PPE donning and doffing. So initially, our PICU team took a lot of pain to teach exactly the way to don and off, where to don and off. And what we did subsequently was, in ICU and in emergency room, we held a competition on a daily basis. So though we showed them how to use a non-impermeable gown to be worn, but for training purposes subsequently, we used regular surgical gowns which could be washed. The idea was to preserve as many PPEs as possible. And what we did on daily basis was created a dashboard and asked nurses, like a competition, to wear PPE and see who takes the shortest time to don and off. And that kind of helped people a lot. And oftentimes, initially, there's a lot of fear about COVID. How do we actually take care of these patients? You know, I might get contract infections. I might have to be quarantined for 14 days to 28 days. And this exercise, especially of training use of PPE, people gain a lot of confidence, and also there's a lot of anxiety. I have to wear a PPE, child comes arrested, it's going to take me some time. Child is very sick, child needs an intubation, I need to wear PPE, that takes a lot of time. You know, when we did this exercise where people have to practice on a daily basis and created some kind of a competition in terms of who takes the shortest time to wear PPE, that not only helped in making sure the PPE is worn correctly, but also made people more confident in terms of wearing PPE in the crisis situation. Then what we did was, like what we just mentioned, we looked into testing the process, especially of the emergency room. We closed the main entrance of the hospital and everyone has to enter through the emergency entrance. And there was a whole triaging system to figure out if the patient was at risk for COVID or not. And then we were concerned what would happen to those sick children who might come to the emergency room and whether we could triage them well or not. And this whole process of running this scenario quite a few times, because when we started off, we identified quite a bit of lacunae. And then what we can see here is once they've gone through zone 0 training of wearing, doffing and donning, they were able to don PPE around 20 to 30 seconds. And nurses got so confident in the end that they didn't find it quite anxious. Oh, I have to wear PPE and then enter, and then the child is sick, the parent is getting upset. And also what we identified was, you know, unlike adult practice, you know, children do come with parents and the parents can potentially be carriers. How do we actually manage these parents? What is a place we need to make them sit? Where would the history be taken? And in terms of figuring out the dynamics of how to handle parents during the situation, running simulation was immensely helpful. And it actually helped us in fine-tuning various aspects of protocol. And this is, again, looking in the transport. So we had quite a few elevators and figuring out how to move the patient, which elevator to use. How do we involve security team in terms of cordoning of the entire area, making sure the lift comes on time, make sure the lift is locked and goes to the correct floor of ICU, does not stop in between and does not take any more passengers. You know, that actually helps security team quite a lot too, in terms of knowing how do actually they deal with the COVID patients. And again, we ran this scenario quite a few times because there were many system-related issues we identified and we rectified it, and we kept on running it till we got the things the way we wanted. And subsequently, through the journey through ICU, we ran scenarios about how do we actually take a patient who's on who's in ICU, lands up developing respiratory arrest, and you need to intubate. The key here for us was about implementing aerosol, because it's aerosol generating procedure. Patient is in negative pressure room. What are the precautions we need to take for this particular child? How do we decrease the number of entry of physicians or the nurses entering into the room to decrease aerosol exposure? How do we use aerosol filter? And how do we avoid bagging? How do we avoid, I mean, essentially bagging procedure post-intubation, which can again generate aerosol. So it was immensely helpful for the nursing staff and for the physicians, because everyone was wary. Child becomes suddenly unwell in ICU. Do we get enough time to wear PPE? What would happen in meanwhile? And when we ran this scenario, a lot of confidence generated among the team that they might be able to wear PPE. You know, it in the end just took around 20 seconds for them to wear PPE and enter the room. And subsequently, we ran a scenario where we had to do CPR. And we, like what the past presenters presented, we figured out a process where we have the least number of people in the room, have a team leader stationed outside who observes the room, all the medications are prepared outside. Even the similar scenario for intubation, all the equipments are kept outside so that the minimal contamination of the equipments happen. Only necessary equipments are sent. So we designed the entire protocol in terms of wearing PPE, minimizing the number of people entering inside, and figure out if it was feasible. When we designed the protocol initially, nurses were very, very concerned. Oh, we're just going to be inside the room, just two of us, no doctors, whether we'll be able to actually resuscitate the patient safely or not. And when they actually went to the simulation, they felt very, very confident that they were actually able to do it. So what I would say in the end was, what we did finally is moment we got any ICU patients, even though they are not COVID, they were absolutely had no symptoms of COVID, we treated them like COVID patients just to test the entire system. Okay, what happens when you get a real patient? And if I were to wear a PPE for 6 to 8 hours and manage a patient, is it possible? So we were trying to look at real life experiences apart from simulation in terms of testing the protocol. How do we move the patient from to the ER? How did we shift the patient from emergency room to the ICU? How did we manage those patients 6 hours in ICU? How can we decrease the exposure of doctors' visits inside the ICU? How can we get a lot of information without entering the room? You know, those kind of things per shift we could actually gauge by taking those patients who are not COVID, but using COVID protocols to ensure that if we get a real COVID patient, we are far more comfortable. By this exercise, what happened was, nurses were initially worried, oh, will I be able to wear PPE for that long? And when they actually managed the patient, non-COVID patients like a COVID patients, they felt, you know, it was not a big deal for them. They could actually manage it quite well. And they felt much more confident and comfortable in terms of taking care of a real COVID patient. So with that, I would just conclude the brief talk of mine. So what we felt was, you know, a lot of planning in terms of what is a clear objective. Are you looking at zone zero training? What kind of debriefing practices you would want? For example, we looked at use of PPE, donning and doffing, use of viral filter for intubation as a very specific zone zero skill. Even experienced physicians had to go through the zone zero training. So it's a common misconception to think that a zone zero training essentially means it's for a really junior trainee. You know, there are many things we might be novice at, and we might have to go through zone zero training. And also it helped us in refining our unit protocols and process. It helped in a lot of interdisciplinary training. I didn't share the work done by our neonatal team and obstetric team. They too ran quite a bit of simulations to figure out what's the best way to manage a pregnant lady, and also running a newborn resuscitation in the operating room. So what happened in the end was initially a lot of apprehension among the team. It actually paved the way to a lot of confidence in terms of managing COVID patients. And this whole COVID experience gave us was quite helpful in many ways. And like I said, you know, when we started in last 4 years, every time we think about building a simulation program, there were many challenges, especially with regards to time. How do you get the nurses to come out? How do you get the doctors to come out? So that was a major challenge. And because many people got freed up with the decrease in clinical work, we were able to train a lot of people in short time. We were able to run simulation on a daily basis. It kind of, so what I would suggest is, a lot of those people who are thinking about starting simulation program, this is probably an excellent opportunity where you have time, where you have people, and actually can do a meaningful difference, because people can see a direct difference in terms of going through simulation and looking at the outcomes. And also what we did was try to get administrators, infection control officers, quality improvement managers to come to the simulation programs, because that gives them a lot of insight too, in terms of not only for us to have a buy-in later in terms of building a simulation program, because they can directly see its impact, also in terms of refining the protocols to take care of COVID patients. So I would just conclude by saying, many of you might be knowing that we are actually running a simulation competition, simulathon rather, not a competition. In the past, we did run on sepsis as well as trauma, and we've been trying to collect information with regards to COVID simulation. And if you have done any simulation last 2 months, or if you plan in next 2 weeks, which I think if you have not done, this is something, is an excellent time, opportunity, space to think about doing simulation and getting a maximum buy-in from your entire administrative team. So please reach out to us. And Dr. Sujata is taking care of the entire simulathon exercise for COVID-19. So feel free to get in touch with us and report your experiences in terms of how did that whole simulation exercise go. So with that, I'll just conclude my talk. And what I'll do now is I'll just take up some questions which have popped up during our presentation. Stop sharing now. All right. So will I have something to add? Yes.
Yeah, I was wondering, I noticed that that in some of the simulations, like the one that Anne presented, they were kind of faking using the PPE in order to preserve the PPE for the real patient. And in some of your simulations, you were using the real PPE and some not all real PPE. I'm just wondering the balance. Maybe Anne and Rakshay and Michael, you might each comment about whether you feel the balance of actually putting on the real PPE is so important that it's worth wasting it, or whether it, or whether that's the right way to do it, or whether you should actually use the real PPE. And can you just say something about how you decided whether to use real PPE or not?
Yeah, so we decided not to for most of our simulations, mainly because the donning and doffing of the PPE was not as important as the processes of moving. We realized that with full PPE on and N95s and goggles, that perhaps there's some other communication challenges that can come up. But I think one had to do with the number of people that were involved in the simulations who wouldn't necessarily be using N95, so there was definitely a conservation. But I think a lot of it had to do with what the actual objectives were of the simulation, and that we didn't feel like using actual PPE was necessary for the learning, for what we wanted to learn and discover.
We had the same experience that when we covered our faces, it didn't have to actually be with the real PPE, but when we actually covered our faces and could only see the eyes and they were behind goggles, the communication that we did during the transports, et cetera, was very much different, muffled, and more difficult. How about you, Michael?
I would say the same. I think it depends on the learning objectives, but I definitely think what we did was issued everyone with one training N95 mask and asked them to keep that for the duration of their kind of practice, and that worked pretty successfully. We also just wrote on surgical masks that this was an N95 at times in order to simulate that at other times. But I think we really found that communication factor and the time factor important to simulate in many situations, but not important if, for instance, you're practicing infection prevention control by transporting a patient through the hospital. So it depends on the learning objective.
Yeah, so for us, what happened was one of our objectives was also to see how much time does it take for you to wear PPE in times of crisis. So it was important for us. So what we did was while training, we trained people using initially with N95 masks, but then when we ran the scenarios, it was not very important for us it to be a N95 mask, in the sense that we replaced that with a surgical mask. We replaced impermeable gowns with the surgical gowns, which can be easily washed and reused. So we just changed the components, but what we were testing was more of, how much time does it take you to wear gowns, mask, and how do you communicate with those on in times of crisis. So that way we were able to wear PPE, use that in the times of simulation, but not really use the ones like N95 masks, which are at shortage, and not waste them during the simulation exercise.
I was also interested, Rakshay, in that your nurses could don PPE in 30 seconds or less for emergencies. In simulations, we tried to do it, and we found that about 2 minutes with an observer was about the limit before we started making a fair number of mistakes or having people rush in before they were really adequately, particularly the wrists where the gowns would meet the gloves were not taped well or were not secured. Did you do something special that allowed you to don so quickly?
Yeah, so a couple of things. there was all, what happened was initially out of anxiety, like you said, a lot of the ways that PPE was worn was not completely appropriate. So there were issues with not wearing N95 properly. There were issues with especially the gloves and the gown interface being completely exposed. That was the commonest issue we noticed. So like I said, what we did was keep this competition on a daily basis of wearing PPE correctly. And also what, so that whoever wears it in short time, it's kind of create a dashboard, and we write down how much time each person took to wear PPE. That kind of exercise helped. And what we did also was to ensure that the PPEs are worn properly. We made the shift in charge nurse as a supervisor person who observes whether the PPE is worn properly or not, like a donning buddy, to ensure that they have worn it properly before they enter, to ensure the completeness of how the PPE is worn. But for us, I think creating this kind of a competition on a daily shift basis of who takes the shortest time to wear PPE among everyone, that kind of helped us in terms of reducing the time towards donning PPE in particular.
I see that we're short on time. For myself, I think what I've learned most through this is that it's a continuous cycle of work as imagined, work as simulated, work as done, which then feeds back into the policies and procedures, work as imagined, etc. That it's one continuous process, and that it works for me more than just for COVID, but really applies to virtually every situation beyond COVID. And we're really going to move to use this more in the new normal, not only in taking care of the COVID patients as they come, but also as we undistance, as we sort of recover from COVID, how to change those policies back to for influenza, other things.
Yeah, I would really echo that, Vinay. I think for us, this is, I think, a real great proof of concept to people that weren't already involved in simulation, that simulation is an incredible force for good within the hospital as a rapid change agent and change enabler, making sure that we can improve rapidly and safely. And I think that really should be the takeaway message from simulation to our hospital leadership, which is COVID's really demonstrated the power of simulation to make our hospitals work better. And that should be harnessed at all times, not just in a potential pandemic situation.
All right, so thank you so much for each of you for sharing your valuable insights in terms of how simulation can really help, especially in the times of pandemic. I appreciate all of you taking time. I know it's been you're all in different time zones, one in New Zealand, one in US, and it speaks a lot. You're taking time and sharing your views with us. Thank you so much, and have a nice day.